Hello students, it's nice to be back with you, and today I'm going to talk about the small intestine and its blood supply. There's nothing small regarding the intestine. It has got a length of 6.25 meters. The only thing small is the diameter when we compare the diameter to the large intestine. Now, the structure of the small intestine, the anatomy of the small intestine is adapted for digestion and absorption. For the purpose of digestion, the part of the intestine known as duodenum has got glands which are called Brunner's glands, and the jejunum and ileum has got intestinal glands or the crypts of Leiberkuchen. Now, the Brunner's glands of the duodenum, they are compound tubuloacinar glands, and they secrete mucus, while the simple tubular glands or the intestinal glands or the crypts of Leiberkuchen of jejunum and ileum, they are having circular openings between the villi, and they secrete enzymes and mucus. Students, you should never underestimate the role of mucus in digestion. Mucus is the thing which protects the wall of the intestines. It lines the wall of the intestines, and then it lubricates the intestines, and then it prevents water loss, and then it traps the pathogens and viruses. So it has got an important role in digestion. So the digestive enzymes and the mucus, they are secreted by the glands in the intestine. The intestinal crypts of Leiberkuchen, they are present, as I told you, between the villi. They have got circular openings, and they are also responsible for digestion. Then we have for absorption, we have got one of the important factors you must keep in mind is the large area of the intestine, the small intestine, 6.25 meters. Out of this 6.25 meters, 25 centimeter is duodenum, and remaining 6 meters, 2/5 is the mobile jejunum, and 3/5 is the mobile ileum. So for absorption, such a large area of the small intestine is there, and that helps in absorption. Other than that, the small intestine has got circular mucosal folds, and these circular mucosal folds, they start from the second part of duodenum, that is the retroperitoneal duodenum, and they are there till the proximal part of the ileum, proximal half of the ileum. So these circular folds, they are more closely set in the jejunum compared to the ileum, and these circular folds, they also increase the surface area for absorption. Other than increasing the surface area for absorption, these circular folds, they help in absorption because they slow down the transit time of the intestinal contents in the gut. So the circular folds, they help in absorption. Other than that, the small intestine has got jejunum and ileum have got finger-like projections which are called villi. Now these are visible with the naked eye, and they are folds, finger-like folds of mucous membrane, and the villi, they help in absorption, and they are large, leaf-like, and more abundant in the jejunum as compared to the ileum, where they are smaller, thinner, and less abundant. So then again, when we look at the columnar cells of the villi, there's the border is has got a striated appearance. That is due to the presence of microvilli, and microvilli one can appreciate by electron microscope. So all these modifications are there which help in absorption from the small intestine. Now, another important thing about the small intestine which I would like to share about you is regarding its lymphatic component. Okay, solitary lymphatic follicles are present in large and small intestines, but aggregated lymphatic follicles called Peyer's patches, they are characteristic of the ileum. Okay, and one more thing is that they are present along the anti-mesenteric border of ileum. Now these Peyer's patches, students, they are affected in typhoid. They are ulcerated in typhoid, and so a typhoid patient has got oval ulcers along the long axis of the anti-mesenteric border. While in case of Cox abdomen, that is tuberculosis of the abdomen, it is not the Peyer's patches which are affected, it is the lymphatics of the intestine which is involved. Now the lymphatics in the intestine has got a circular course. Okay, so once these lymphatics are involved in tuberculosis, then when healing takes place of these circular ulcers in tuberculosis, then there is a constriction due to healing by fibrosis, and that leads to intestinal obstruction. So ulcers may occur in typhoid as well as tuberculosis in the intestine. The typhoid ulcers are oval along the antimesenteric border, while the tuberculous ulcers, they are circular, and during healing they can cause intestinal obstruction. So this you should know. And then there is another aspect, that is the nerve supply of the intestine, small intestine. Well, you know, it is under autonomic control. Okay, digestion takes place and we are not even aware of it, it's taking place. Now the supply is autonomic, so it means it is sympathetic and parasympathetic. So you keep in mind that the parasympathetic supply, which in case of small intestine is by vagus, that the parasympathetic nerves are evacuatory in nature. Now, when we say evacuatory in nature, what do we mean? They will stimulate peristalsis and they will relax the sphincters. The sympathetic supply of the small intestine is by T9 to T11, and these nerves, you know, they are having an opposite action to the parasympathetic system. That is, they will cause constriction of the sphincters and they will relax the peristaltic muscles. So if you have this backdrop in your mind, with this backdrop, I will now go to a small PowerPoint wherein I will highlight what all can be asked in the examinations to you. So now the small intestine and its blood supply. Now the duodenum is lying above the level of the umbilicus, and it extends from vertebra L1 to L3. Okay, because we all know that the umbilicus, it lies at vertebral level at the disc between 3-4 lumbar vertebra, third lumbar and fourth lumbar vertebra. So duodenum lies above the level of the umbilicus, that it lies at the above the junction of third and fourth lumbar vertebra. So the duodenum lies from L1 to L3 and it is C-shaped. You can make out it is C-shaped, and in that concavity of the C lies the head of the pancreas. So an important thing is that the duodenum is 25 centimeters long. There are some structures in our body which are 25 centimeter long, including the ureter, the duodenum. We'll again come to that when we do the ureters. For the time being, you should know that the duodenum is 25 centimeter long and it is made up of 4 parts. The first part is 5 centimeter long, then we have the second part, third part, and the fourth part is 2.5 centimeter long. Now this first part, it forms an important relation of epiploic foramen. It forms the inferior relation of epiploic foramen. And this first part, which is 5 centimeter long, its proximal half, that is the initial 2.5 centimeter, they are intraperitoneal, while the remaining 2.5 centimeter, they are retroperitoneal. So this first part is very much prone to duodenal ulcers. Okay, so that you should keep in mind that the first part is prone to duodenal ulcers. Now, I'll again come back to this slide only. Why the first part is prone to duodenal ulcers? Well, the reason for that is that, you know, ulcers, they happen in the first part of duodenum because the stomach releases acid, and that acid has an effect on the first part of duodenum because it lies closer to the pyloric sphincter. Now, normally what happens is that the Brunner's glands, they secrete mucus and they counteract the effect of the acidity from the stomach. But in persons who are highly stressed, you know, what happens is the sympathetic system, it overpowers the parasympathetic system, and due to overpowering of the parasympathetic system, the sympathetic system is not counteracted by the parasympathetic system, and so ulcers, they develop in the first part of the duodenum. So they are more likely to happen in persons who are highly stressed. That is why they say don't take stress in life. So this, the duodenal ulcers, they are characteristically worsened by work, worry and weather, because that will activate the sympathetic system. And then another thing regarding the first part of duodenum is that if we take an barium X-ray of the first part of duodenum, it gives a triangular appearance with apex above and base down, and this is called duodenal cap appearance. Now students, there are various anatomical factors responsible for this duodenal cap appearance. So what are those factors? One of the factors is that the first part of duodenum, it goes upwards and backwards. It goes upwards and backwards, and then it goes downwards. So what happens is, because it goes upwards and backwards, when the barium meal it goes upwards and backwards, then that gives the appearance of a triangle. And second thing is that this viscosity of the barium meal is there. So once the barium meal comes out of the pyloric sphincter, it is like a toothpaste coming out of you've seen a toothpaste coming out, and similarly is the viscosity of the barium meal. So it is like the toothpaste coming out of the nozzle. It is like the barium meal comes out from the pyloric sphincter, and it gives the appearance of a triangular cap. As I told you before, the circular mucosal folds are absent in the mobile part of the duodenum. So what happens is that it gives a smooth shadow, it gives a triangular shadow, and while the retroperitoneal part of the duodenum is collapsed and there are circular folds present there. So there the radiological shadow will be floccular shadow, what we refer to as the feathery appearance, while the first part of the duodenum gives the appearance of, the mobile part of the duodenum gives the appearance of the triangular duodenal cap. So you should keep these anatomical factors in mind. Now we come to the second part of the duodenum. Thing is that this is asked in the examinations, that diagrammatically depict the second part of the duodenum, or sometimes a note comes that describe the second part of the duodenum in terms of its relations. Well, you should remember that this second part of duodenum, which is represented by these green dotted lines, anterior to this lies the right lobe of liver, as you can make out here. Then you have the transverse colon and the transverse mesocolon, and then you also have some coils of small intestine. So these are the anterior visceral relations of the second part of duodenum. Well, you all know that the second part of duodenum is retroperitoneal and fixed. So posterior relations of the second part of the duodenum. Here you can again make out. So posterior are dotted structures. You can make out the medial aspect of the kidney, the anterior part of the anterior surface of the medial aspect of the kidney. So the posterior relations include the medial part of the anterior surface of the kidney, a part of the inferior vena cava you can make out here, renal vessels you can make out here. So they are the posterior relations of second part of duodenum. And students, this question is definitely asked in the examination, so you have to practice these diagrams. You can't get away with leaving these diagrams. So do spend time, take up the pencil in your hand, use the paper, and start trying to make these diagrams so that they are imprinted in your mind and you do well in the examinations and your comprehension is also improved. Now third part of duodenum, again it is retroperitoneal and fixed. Then this third part of duodenum, anterior to it lie the superior mesenteric vessels, the artery and the vein, and also lies anterior to it the root of the mesentery. Okay, now this root of the mesentery is there, and it is forming the anterior relation of the third part of duodenum. Then we have the visceral relations of the third part of duodenum, the posterior relations. Okay, now the posterior relations include, as you can make out in the diagram, the ureter, the dotted yellow portion here. Then you have got the psoas major, right psoas major muscle. Then you have got the big vessels, the inferior vena cava and the aorta. The inferior vena cava lies towards the right of the abdominal aorta. Then you have got the inferior mesenteric artery, which arises behind the third part of duodenum. And then you have the gonadal vessels, they are also passing behind the third part of duodenum. So students, do practice these diagrams. They are asked in the examinations. Then there is another question, you may get a 5-mark question on Meckels diverticulum. Now, what is it? It is the persistent proximal part of vitello-intestinal duct. I hope you remember the journal embryology I taught you. Normally, it disappears by 6th week of intrauterine life. So here it is, the vitello-intestinal duct passing from the midgut loop up to the yolk sac. So this should disappear by 6 weeks of intrauterine life. However, if it persists, then the proximal persistent part is referred to as the Meckels diverticulum. Now, there are 5 important things regarding this Meckels diverticulum which you should write in the examinations. That is, it is present in 2% of the subjects, it is 2 inches long, it is present 2 feet proximal to the ileocecal valve, its diameter is equal to ileum, and its apex may be free or may be attached by a fibrous band to other structures in the vicinity. So do mention these 5 points. They will fetch you marks in the examinations, and do draw this diagram and tell about the embryological origin of the Meckels diverticulum. So there is a clinical aspect also, that inflammation of Meckels diverticulum resembles appendicitis. So symptoms are like that of appendicitis. Person may have symptoms of appendicitis, but when he is operated upon, he or she is operated upon, they find it's not the appendix which is to be blamed, it is the inflammation of the Meckels diverticulum, and this Meckels diverticulum may also cause intestinal obstruction. Next, we come to the blood supply of the small intestine. Now, the blood supply of the small intestine, this second part of duodenum where the bile duct is opening. Above this portion is the upper part, the part above this portion is derived from the foregut, and the part below is derived from the midgut. So, the part above is supplied by the superior pancreaticoduodenal artery, while the part below the opening of the bile duct is supplied by the inferior pancreaticoduodenal artery. The hepatopancreatic ampulla, it opens in the second part of duodenum. The major duodenal papilla is there, and the accessory pancreatic duct opens in the minor duodenal papilla. The major duodenal papilla is 8 to 10 centimeters distal to pylorus, while the minor duodenal papilla is 6 to 8 centimeters distal to the pylorus. So this opening of the bile duct, above it lies foregut, below it lies midgut. So the part above the opening of the bile duct is supplied by a superior pancreaticoduodenal artery, while the part below is supplied by a branch from the superior mesenteric artery, that is the inferior pancreaticoduodenal artery. So, celiac trunk is the artery of foregut, while the superior mesenteric artery is the artery of midgut. So, this opening of bile duct represents the junction of foregut and midgut. Okay, first part of duodenum, it receives additional blood supply from the branches from the gastroduodenal artery, from the right gastric artery, from the supraduodenal artery or the artery of Wilkie, which is a end artery, and then you have also got branches from the right gastroepiploic artery. And students, I told you that duodenal ulcers are common in the first part of duodenum because of the hyperacidity there. One vascular reason is also there because this region is supplied by an end artery, the supraduodenal artery. So that also makes it more vulnerable to ischemia. So it is more vulnerable. The first part of duodenum is more vulnerable compared to the rest of the duodenum for duodenal ulcers. Now, what about the arterial supply and venous drainage of jejunum and ileum? But before that, once again, I've told you the arterial supply of duodenum. The venous drainage of duodenum, you can remember that portal vein is formed by union of superior mesenteric and splenic vein. So, portal vein, superior mesenteric and splenic, they are all supplying the duodenum. They are the venous drainage is to all these 3 vessels. Now we have the blood supply of the jejunum and ileum. Well, the superior mesenteric artery is giving jejunal and ileal branches. So jejunal and ileal branches, they will supply the jejunum and ileum. Okay, so they are branches from the superior mesenteric artery, and the corresponding veins, they will drain the jejunum and ileum. So then we come to the differences between jejunum and ileum. This again is a very important question, and it is asked in the examinations. Tabulate the differences between the jejunum and ileum. So first thing you will tell is that where are they located relative to each other. So ileum is located in the right part, while jejunum is located in the left and upper part. So ileum in the lower and right part. Then you remember that jejunum, it's the initial part. It is wider, emptier, thicker, and vascular. I used to remember it like that, WETV. Wider, emptier, thicker, and vascular. What is that? That is jejunum. So the ileum will be, it will not be wider, it will be narrower, it will not be empty, so it will be loaded. It's the lower part, it will be loaded. Then thick, it will not be thick, it will be thin, and it will be less vascular. So wider, emptier, thicker, vascular is jejunum. And then you remember circular folds and villi. What can be the differences in circular folds and villi? We have already talked about it initially also, that in jejunum, the circular folds are larger and closely set, and the villi are large, thick, leaf-like, and more numerous, while in ileum they are shorter, thinner, and less. The solitary lymphatic follicles are more in ileum, and Peyer's patches are present here while they are absent in jejunum. So you should know these differences, and then you also have to mention the differences in mesentery of jejunum and ileum. So what are the differences in mesentery of jejunum and ileum? So here we see the mesentery of jejunum, and here we see the mesentery of ileum. So you can make out the yellow portion is the fat. So the fat is more in the ileum mesentery, while it is less in case of the jejunal mesentery. There are some fat-free areas called windows present in the mesentery of jejunum. Then the arterial arcades are 1 to 2 in the jejunal mesentery, while there are 3 to 6 in the ileal mesentery. And then the vasa recta in the jejunal mesentery are they are less in number and they are longer, as you can make out, while the vasa recta here in case of ileal mesentery, they are shorter and are more numerous. So with this, students, we come to the end of today's class. Do read the notes and do practice the diagrams. So till the next time we meet, it's bye from me now. Take care. Bye bye, and thank you for your cooperation.